Hello, my name is Sergio Kaiser. I'm a professor of internal medicine at the Rio de Janeiro State University and also a practicing cardiologist. Our talk today will be about how we can optimize the use of PCSK9 inhibitors in patients at high risk of cardiovascular events. We know that these drugs are very expensive, so it's very appropriate to find the right patient who has the best chances of deriving more benefits from the use of these drugs. This slide comes from the Global Burden of Disease study, and it shows that in 2015, cardiovascular diseases were #1 killer in most parts of the world. For instance, in Latin America, it was responsible for 50% of the deaths. In North America, cardiovascular diseases accounted for 62% of the deaths. This is an ever-growing problem since population is growing older. So how can we tackle that? The good news is that since its peak in the 60s, cardiovascular mortality has been experiencing a sharp decline. And there are several reasons to explain it. The better access to health care, new drugs, new devices, and the widespread use of heart-protecting drugs such as statins, beta blockers, ACE inhibitors, and aspirin. Probably the main drivers of this sharp decline in cardiovascular mortality throughout the years are the control of blood cholesterol and systolic blood pressure. On the other side of the graph, however, the increased prevalence of obesity and type 2 diabetes have partially neutralized this benefit. It is now widely accepted that the two main triggers of the atherosclerotic process are related to ApoB containing lipoproteins and inflammation, whether overt or in most cases subclinical. The interaction of these two components may be enhanced by the traditional risk factors. This robust evidence is supported by experimental, genetic, observational, and therapeutic studies. Evidence derived from randomized controlled trials such as the CTT meta-analysis, which assembles statin trials, as well as trials that evaluated non-statin drugs, demonstrated a clear relationship between ApoB lipoprotein reduction and cardiovascular events reduction. On the inflammatory side, we could only infer a possible anti-inflammatory effect of rosuvastatin, for recruited patients for the Jupiter study had to have increased CRP levels but not increased LDL levels. Upon the publication of the Canto study, the loop was finally closed when it was demonstrated that the monoclonal antibody canakinumab targeted at blocking the interleukin-1 beta axis reduced cardiovascular outcomes without affecting plasma lipid levels. First, let's make a brief review of the main lessons learned from lipid-lowering therapeutic studies that were carried out throughout the last 30 years. According to the CTT meta-analysis, we can see that the reduction in relative risk of cardiovascular events is linearly related to a reduction in LDL cholesterol levels. This is valid for statin as well as for non-statin trials, where the drug studied led to an increase in LDL receptor density. So for every 39 milligrams per deciliter decrease in LDL cholesterol, there's a 21 to 28% decline in the relative risk of cardiovascular events. On the other hand, the higher the absolute risk of suffering a cardiovascular outcome, the larger the benefit that can be obtained through LDL cholesterol reduction. This means that the number of patients needed to treat during a period of time equivalent to the duration of most trials in order to prevent one cardiovascular event will be smaller for those at high cardiovascular risk. It turns out from the depicted graph that combines the absolute 5-year cardiovascular risk and the magnitude of LDL lowering, that those at very high risk with the most intense LDL reduction are the ones with the largest absolute benefits from therapy. Notwithstanding the significant achievements in cardiovascular disease prevention after the introduction of statins, patients still suffer from heart attacks, strokes, and other manifestations of atherosclerotic vascular disease. Despite achievement of a recommended LDL goal, people at high risk are usually sicker and thus are exposed to a high residual risk, as can be depicted in the far right bar of this graph, where patients, even when optimally treated with statins and with ideal LDL cholesterol levels, had the highest cardiovascular event rate. Let's examine, for instance, patients allocated to the placebo arm of the IMPROVE-IT trial. This was a 7-year duration trial where subjects discharged from an acute coronary attack were randomized to either simvastatin alone or simvastatin plus ezetimibe. A set of 9 easily obtained clinical independent risk factors for a second event was identified, and patients were stratified according to escalating combinations of those risk factors. There was a clear incremental risk proportional to the clustering of markers, in a way that those presenting with 5 or more had an almost 70% chance of having another event. This is known as the TIMI RS2P, which means the TIMI group risk score for secondary prevention. Now let's briefly review the main results of the Fourier and Odissey Outcomes study, which respectively investigated the effects of the monoclonal antibodies evolocumab and alirocumab in patients at very high cardiovascular risk at maximally tolerated doses of statins with or without ezetimibe, who were still out of their desired lipid level goals. First of all, let's review the role of PCSK9 in lipid homeostasis. These initials stand for proprotein convertase subtilisin 9, a substance that was discovered in 2003 and regulates the density of LDL receptors at the surface of the hepatocyte. LDL receptors are able to recognize and attach to the circulating LDL particle. Both are then internalized in clathrin-coated vesicles, and when they reach the lysosome, LDL is released and metabolized. The receptor then goes back to the surface, and this kind of shuttle action repeats about 150 times before the receptor is degraded. PCSK9, when secreted into the circulation, attaches to the complex LDL particle receptor and prevents its release into the lysosome. Instead, the whole complex will be degraded and the receptor density at the hepatocyte surface will decrease. Consequently, LDL plasma levels increase. Despite blocking the rate-limiting enzyme in cholesterol metabolism, statins also stimulate the secretion of PCSK9, which in part neutralize the LDL-lowering effect of statins. A monoclonal antibody targeted to the active site of circulating PCSK9 prevents it from adhering to the complex, leading to an increased receptor density and a sharp and long-lasting LDL plasma levels reduction. It's worth mentioning that the potential of alirocumab and evolocumab to generate immune responses is minimal because they're fully humanized without any animal fragment in their structure. So, let's briefly review the main results of the Fourier study. This was a randomized double-blind controlled trial in more than 27,000 patients with stable atherosclerotic disease, either a previous myocardial infarction, overt atherosclerotic heart disease, or peripheral arterial disease. After a run-in period, those with LDL equal or above 70 milligrams per deciliter or non-HDL equal or above 100 milligrams per deciliter, despite optimal statin doses, were randomized to subcutaneous injections of evolocumab twice monthly or corresponding placebo injections and followed up for a mean of 2.2 years. Mean LDL levels fell almost 60%, and this difference in relation to placebo was kept rather constant throughout the study. After a median follow-up of 2.2 years, the study was halted due to a relative risk reduction of 15% of a 5-outcome composite pre-specified primary endpoint of cardiovascular death, myocardial infarction, stroke, emergency admission for unstable angina or coronary revascularization. The absolute 2% reduction in the primary endpoint that was documented translated into a number needed to treat of 50 patients with evolocumab during 2.2 years to prevent one of these outcomes. A key secondary endpoint composed of the 3 first outcomes was reduced 20%, and also with a 2% absolute risk reduction and an NNT of 50. Of note, the curves began to separate at 6 months and there was no reduction in cardiovascular or all-cause deaths. A further and very interesting exploratory analysis addressed a group of 504 patients whose LDL levels at 4 months reached values below 10 milligrams per deciliter. The risk reduction in primary and key secondary endpoints was even more pronounced when compared to the rest of the cohort without any safety concerns. And what about the Odyssey Outcomes trial? Its main results were presented at the ACC meeting in March 2018, but up to the time of this presentation, they have not yet been published. Patients enrolled in the Odyssey trial were also at high risk of subsequent events. All of them should have suffered an acute myocardial infarction or should have had an acute coronary syndrome between 1 and 12 months before enrollment. They also had to be on maximally tolerated doses of high-potency statins with or without ezetimibe, but would not have reached their recommended LDL or non-HDL or ApoB goals, that is, lipid levels were inadequately controlled. The primary composite endpoint was a 4-outcome endpoint composed of cardiovascular death, myocardial infarction, stroke, or unstable angina requiring hospitalization. This slide shows some of the main differences between Fourier and Odyssey outcomes. In Fourier, patients had stable disease, and in Odyssey, all of them had a recent acute coronary syndrome episode. Coronary revascularization was not included as a primary endpoint in Odyssey outcomes, and this study had a longer follow-up than Fourier. There was a high proportion of patients on maximal doses of statin in Odyssey, and a minimal proportion of patients off statins in Fourier when compared to Odyssey. In the Odyssey outcome study, prespecified secondary events were analyzed in hierarchical order. That's it. If the first set of events analyzed was not significantly different from placebo, the next set of events should not undergo statistical analysis. As can be seen, the last secondary endpoint in the pre-established hierarchical order was all-cause death. Briefly, Odyssey Outcomes was a randomized, double-blind, placebo-controlled trial which recruited almost 19,000 patients after an acute coronary syndrome episode. After a run-in period, they were randomized to either 2 monthly subcutaneous injections of alirocumab and corresponding placebo, and followed up for a median of 2.8 years. In the beginning of the trial, LDL levels fell sharply in alirocumab-treated patients, with a mean 63% difference relative to placebo, which was attenuated along the course of the study. This attenuation was not due to autoantibodies production. On intention to treat analysis, the difference in LDL cholesterol levels between alirocumab and placebo was even smaller, but we should wait for the publication to better understand what happened. There was a highly statistically significant 15% reduction in the primary prespecified endpoint corresponding to a 1.6 absolute risk reduction. It should be emphasized that primary endpoints in both trials, Odissey and Fourier, showed a similar result when in the same direction, which reinforces the validity of further lowering LDL to prevent cardiovascular events in high-risk patients. This slide depicts the hierarchical endpoint analysis. Everything went well. Difference between treated and placebo groups were highly significant for all secondary endpoints until they reached coronary and cardiovascular death. Then there weren't significant differences between alirocumab and placebo. The analysis, despite being supposed to stop, proceeded, and the authors actually found a difference in all-cause death with a p-level of significance of 0.02. Since this wouldn't be, let's say, an officially reported difference, this p-level was labeled as nominal. Another curious analysis by the investigators addressed the stratification of patients according to pre-randomization LDL levels into three subgroups: those with less than 80 milligrams per deciliter of LDL cholesterol, another group with LDL between 80 and 100 milligrams per deciliter, and a third group with LDL equal or above 100 milligrams per deciliter. The only significant relative risk reduction was observed in this third subgroup, but this interaction between treatment and pre-randomization LDL levels did not reach statistical significance. Below is the same graph magnified for better visualization. In summary, only patients with LDL equal or above 100 milligrams per deciliter derived any benefit from alirocumab treatment, comparing to placebo. Once again, we should wait for the publication for more details. And now we reach what is possibly the most interesting part of this presentation. Patients in secondary prevention are a heterogeneous group composed of subjects with different levels of risk. So can we further stratify them and thus select the most needy of aggressive treatment? In this regard, there were several pre-specified sub-analyses published after the main Fourier results, which provided a good framework for further stratification of these patients. Let's start with diabetes and take a look at this publication. About 40% of the Fourier cohort suffer from type 2 diabetes. Despite a slightly higher relative risk reduction, the absolute risk reduction was significantly higher, translating into a number needed to treat with evolocumab of 37 patients for 3 years to prevent one outcome, as compared to an NNT of 62 in non-diabetics. Now let's go back to the TIMI RS2P score that one derived from IMPROVE-IT study explained a few slides back. This score was applied to the Fourier population, and results were very similar. Those with 5 or more easily collectible clinical risk factors had an almost 19% chance of experiencing a subsequent event. And what happened? As the cluster of risk factors increased, the NNT for evolocumab decreased down to 28 in the highest risk category. Patients with peripheral artery disease are at particularly high risk of cardiovascular events. On the left side of this graph, it is possible to clearly note that patients with peripheral artery disease, or PAD, in Fourier had almost twice as much risk of having another event compared to those without PAD. And on the right side graph, we also see that those PAD patients who also had a previous stroke or a myocardial infarction or both had distinct and worse prognosis. As compared to patients without PAD, those with PAD had a striking 3.5% absolute reduction in risk, corresponding to an NNT of 29 as compared with 72 in the group without PAD. In another recently published Fourier substudy, patients were stratified into three groups: those with the myocardial infarction less than 2 years before enrollment, as compared to patients with infarcts more than 2 years before enrollment. Another analysis separated patients with only one qualifying infarct and compared them with patients with one or more previous infarct before enrollment. A third analysis addressed patients with multivessel disease versus one vessel disease. As NNTs were similar for the three analyses, patients reported a range of variation instead of absolute numbers. In the first analysis, relative risk reduction for alirocumab were significant and much higher, and number needed to treat much smaller in patients with a more recent qualifying infarction. Similar results were seen for those with one or more previous infarcts before enrollment. An 18% relative risk reduction against a non-significant 8% reduction on the other side, and a smaller number needed to treat to prevent one event in those with one or more prior myocardial infarctions. Also similar results for multivessel versus those with one vessel disease. A significant relative risk reduction with better number needed to treat on the left and no significant difference on the right graph with much higher NNTs. Another Fourier substudy, now separating patients according to their inflammatory status, expressed as high sensitivity C-reactive protein levels before randomization. Those with CRP above 3 were at a higher risk as expected, and there was a graded increase in risk as CRP progressed to higher concentrations. Absolute risk reductions with evolocumab were proportionally higher for those with higher baseline CRP levels, suggesting even some potential benefit of LDL reduction on inflammatory status in patients at such high risk. In conclusion, the benefits generated by LDL-lowering therapy with PCSK9 inhibitors and secondary prevention can be optimized by further risk stratification, increasing thus the chance of preventing a cardiovascular outcome at a possibly lower monetary burden on the healthcare system. And with this final slide, I finish my presentation. Thank you very much for your audience.